Good morning, everyone. A warm welcome to our webinar. So we'll directly start with our first talk of the session by Dr. VISHALI Gupta. Dr. Gupta is an internationally acclaimed vitreoretina surgeon and uveitis specialist, and currently a professor and head of retina services at PGI Chandigarh. She is also the general secretary of the IUSG and the past scientific chair of VRSI, and currently serving as the president of the Uveitis Society of India. Uh, Ma'am has also published over 250 manuscripts in peer-reviewed literature and will be speaking on the story of fluid in AMD. So I'm going to stop sharing and over to you, ma'am.
Thank you very much, and thank you, COS, for giving us the opportunity to talk about retina on a Sunday morning. Not an easy thing. Anyways, my topic is about the story of fluid in neovascular AMD. Now, we all know that we look at the fluid and we start injecting, and it's kind of become a very automated reflex that you see fluid, you inject. But if we look back, how did this fluid come into business? If we look at the major trials which have happened in neovascular AMD over a period of time, starting with the CAT trial and going up to the rival, all the trials, when they started treating, they realized that any fluid on OCT in PRN or in treat and extend was important, because that is what when you decide to re-inject. It started long time ago with time domain OCT, even with low resolution, any fluid we were injecting, and then going on to the spectral domain OCT with the bigger trials and the more recent trials actually, Harbor, Hawk and Area, CQAP, they all look at the fluid. Not only the trial, the various societies, EURetina, American Academy, they all recommend that it is always the OCT now, not the fluorescein, not the ICG, it's the OCT, and you look at the fluid on OCT and you decide whether the patient needs injection or not. So the fluid has become a very important practical aspect of assessing the disease activity, in other words. What is the relevance? Fluid is important in making the diagnosing, in deciding time to treatment, in treat and extend, or in PRN, about treatment interval. And what I'm going to highlight is that if you look at the fluid, it's also going to predict or help you predict the visual outcome. There are actually three types of fluid that we see in AMD, in neovascular AMD. The first one here is this fluid. This is the fluid which is under the retina and the RPE. Somehow, you will see that we don't pay much attention to fluid under the RPE, and that's a mistake, because this is where the whole disease is. The neovascular membrane is actually, this is the site. So this may be early sign of the active disease and should not be ignored. Then you see the fluid here, which is number 2. That is the subretinal compartment, because that is where the choriocapillaries are proliferating. And finally, number 3 is the fluid where the fluid is intraretinal fluid. Now, this is the fluid that causes neurosensory functional deficiency associated with cystic degeneration of retina and subsequent visual loss. So if you see the intraretinal fluid, the chances of visual loss at presentation are more. So this is the sequence of event, but if you look in the practical life, all the retinal fluid, whichever compartment you are seeing, is considered the disease state and needs to be controlled with the treatment strategies. Now let's start with intraretinal fluid, that is the number 3 fluid, because I said that was the bad guy here. So this fluid can form intraretinal cyst. So if you are seeing this fluid, the cyst here at the baseline when patient comes, it kind of is going to tell you that the visual outcome is going to be poorer. If it's not present at the baseline but comes somewhere later, or it is persisting despite the treatment, again it means bad news. The visual outcome is not going to be so good. So now let's look at what trials have said about intraretinal fluid. The post hoc analysis of view 1 and 2 indicate that presence of intraretinal fluid at baseline is a bad news because it means the visual acuity is not going to be so good. Secondary analysis of the CAT study indicates that persistent intraretinal fluid is associated with poor visual outcome during anti-VEGF therapy. Post hoc analysis of EXCITE indicates that new intraretinal cysts early after the loading have been associated with subsequent visual acuity decline. So if the cysts are not there, they have responded and the new cysts appear, even that is a bad news. So intraretinal fluid we saw is a bad news, a bad guy. Now comes the second category of the fluid, which is a subretinal fluid. Now, this is the fluid which is a kind of a bit controversial, which is not such a bad guy actually, because many studies have shown that if you see only SRF at the baseline, and even if there is a little bit of subretinal fluid, after your injection, it is actually associated with either better or stable visual outcome. So, however, when we go to these studies, and I'm going to show you the studies, what they indicate. VIEW study did the secondary analysis of subretinal fluid, and they reported that if there is a subretinal fluid at baseline, it honestly did not affect the initial visual acuity and had a relatively positive impact on visual outcome during anti-VEGF therapy. Secondary analysis of CAT study indicated that if the SRF was persistent, it did not adversely affect the visual outcome during anti-VEGF treatment. Ancillary study of EXCITE indicated that even if SRF keeps on coming back and again, that will not be a good sign. Now here comes a bit of a twist in this story. If SRF is present at baseline, good visual prognosis. Even if little bit of remains during the treatment, it's fine. But if it keeps coming back again and again, it will cause poorer visual outcome. There was a very interesting study, that is the fluid study, which studied the effect of tolerance of some subretinal fluid. So what they did, they dried up first 3 injections, and then there were 2 groups. If the SRF was totally, had to be totally dried up, that was called intensive arm. But on the other hand, they had a relaxed arm. Relaxed arm means that if the SRF was around 200, up to 200, they would tolerate, they would not inject more. So we had 2 groups, whether you want to bone dry it or you are tolerating a little bit of SRF. And this study reported no significant difference between the intensive group and the relaxed group for mean change in baseline visual acuity from baseline till 24 months. So this study actually indicated that if you have SRF, which is little bit persistent, it is not coming back, it's not recurrent, it's not increasing, probably you can tolerate it. You don't have to chase the patients to make it bone dry, because this much subretinal fluid will be tolerated and doesn't affect the visual acuity worsely. Just to show you an example of a patient, now you can see this is a patient with AMD, and this is a presentation. You mostly have subretinal fluid here. So as per our, whatever we have read so far, it should have a good visual prognosis. So this is how it happens. This is 3 monthly doses have been given. It's dry. So you are not doing anything, just following it up, and 9 months also, it's not come back. So this is the kind of a better visual outcome kind of a status. However, if we go back to the fluid study, there is unresolved SRF, which, if allowed, more than 200 micrometer of SRF, which is allowed to be there for a very long time, that sometimes causes development of intraretinal fluid. So intraretinal fluid we already learned was a bad guy. So what happens is subretinal fluid on its own may be tolerated, but if it is coming back again and again, if it is increasing, so then it itself can cause the development of intraretinal fluid, which is a bad news. Now coming to the third category of the fluid, which is the sub-RPE fluid. Now here we would say not many studies have actually paid attention to sub-RPE fluid, and not many studies have measured the length of the pigment detachment and all. However, whatever data is available that suggests that changes in the sub-RPE space could be an early indicator of active recurrent disease, because as I mentioned previously, this is the site where the disease is actually beginning. Post hoc analysis of view 1 and 2 studied the effect of baseline pigment epithelial detachment on visual acuity, and they reported that presence of PED at the baseline had very little impact on initial visual acuity or visual outcomes during the anti-VEGF therapy. So you really don't have to, according to them, worry much about PED. Secondary analysis of CAT study again said the same thing, that sub-RPE fluid did not impact the visual outcome during anti-VEGF treatment. However, the real life, some retrospective studies indicated that PED is associated with poor visual improvement in neovascular AMD in real world setting. Another retrospective study indicated that early changes in the sub-RPE space are actually indicative that there is going to be recurrence, and if you want to nip the evil in the bud, so you got to pay attention to it and you cannot really ignore it. I'll show you two case examples to just illustrate what we mean by this. Now, this is a patient, honestly, on fundus, you don't see much happening, but when you look at it, mostly the action is happening beneath the pigment epithelial detachment. So if you are treating this patient, what you have to monitor is the height of the PED. So following injection, this is what you can see. This is before, and reduction in the height of the PED. Increasing height of the PED itself will be a very early indicator that disease is coming back. Another example, this is type 1 CNV, very clear, shown on ICG fluorescein. And when we look here, there was mostly subretinal fluid. The prognosis would have been very good, and vision was also good at baseline 6/9, and that is what we learned, that subretinal fluid, is a good thing to respond, and you give 3 injections, responded, but there was this little streak of fluid beneath the PED. Now, is it important? Is it not important? But the thing is, even if it's there, you should be monitoring this patient very closely, even if you are not injecting. Now, our patient had good visual acuity and was lost to follow-up. And let's see what happens. When he comes back 14 months later, there is that fluid under the RPE, which is definitely increased, and there is subretinal fluid, and there is that bad guy intraretinal fluid. So from that little streak which was persistent, the membrane has now gone on to full. So the vision is not 6/9 now, the vision has definitely gone down, and we are injecting but even after 6 injections, the response is not as good as it would have been had we dealt with it at the earliest. So, this is the story of the fluid that continues to evolve, which means any fluid anywhere. That indicates the disease is active. The resolution of fluid is important because that correlates to visual benefit. The magnitude, however, may vary. And the more stable CST means better disease control, which means better visual outcome. And of course, you are going to hear Nishikant talking about Hark and Harrier and all those studies, where you would realize how important it is to take care of the fluid. Thank you very much for your patient hearing, and that's all from my side.
Thank you, ma'am. That was really a great talk. We have just a couple of minutes for two questions. So if any of the other speakers have any other question, you can ask. Meanwhile, I'd like to ask, ma'am, you've very rightly pointed out the bad guy, the intraretinal fluid. So if you were to summarize, ma'am, the localization of fluid in various spaces of the retina, how would you sort of, in the order of good to bad, how would you place the fluid in different compartments?
I think sub-RP fluid is good in the sense, not that it's good, but it indicates the very early form of the disease. The disease where the neurosensory retina is not yet affected. And now with NGOCT, we have the opportunity to look for the neovascular complex and treat it. So subretinal fluid should not be ignored, and contrary to the very early studies like CAT and all, where they did not pay much attention to PED, I think this needs to be paid attention, and it should be managed at the earliest. Subretinal fluid, only subretinal fluid is a good sign. And though most of the studies say subretinal fluid is associated with better visual acuity, but I think that is because it's only the healthy RPE which can produce fluid. And it's good because it's not totally dried up or atrophied. So if you are seeing little bit of the fluid, the vision is good because it's not totally undergone atrophy. It's indicative of healthy RPE. So if my patient, say, has a vision of 6'9" and 150 micron of fluid, I will not really keep on chasing and making it dry, but I will keep it under observation, maybe with Octa or without Octa, if somebody doesn't have, to see how this fluid is progressing. If this is progressing, we may inject. If it's not, we may just hold on. Intraretinal fluid means you have allowed the disease to be there for quite some time, and already in the neurosensory retina is this. So if you're seeing patient at that point of time, you do have to treat aggressively, but again, the visual prognosis may not be as good.
Thank you, ma'am. Any other comment, Dr. Dogra sir? Would you like to?
I congratulate Dr. Vishali for a very nice talk and clarifying all the things so well. One of the things which I would like to say about especially the sub-RPE fluid, I think we still go back to that avascular and vascular PED business even before OCT came in. I think most of the time we are not treating all sub-RPE fluid. So many of these, which they're like a PED, even a larger one, and we don't find on Octa any neovascularization, they are not treated. And it is only once they develop neovascularization, even if they are, we have seen this evolution even in cases. I have quite a few examples of these PCV cases where from a small PED, it keeps on growing over a year and for many years, and nothing happens. The vision is 6.6, so you don't tend to treat them. So is I think sub-RP, what you talked about, the subretinal fluid. I think very nicely you presented the data. I think it will be always, even if we have a fluid study or other studies, if it is progressing, the fluid is increasing in the subretinal space, maybe I think we tend to treat then. Otherwise, we also know that this kind of a fluid we see in so many other diseases where it stays there for quite some time. It doesn't damage the retina. So I think you have done a wonderful job there. And intraretinal, of course, I think you mentioned very rightly, that is the major culprit. We can't let it be there. So these are some of the things which I thought I'll just
Thank you.
mention. Yeah.
Thank you, sir. So